Chapter 21, The Normal Newborn Adaptation. Please review the videos on Moodle regarding fetal circulation in the transition to neonatal circulation. During fetal production, fetal lung fluid expands the alveoli and aids in the lung development. This production decreases as the fetus reaches term. During labor, this fluid is moved into the interstitial spaces where it's absorbed. This process can be delayed in a cesarean birth and is not uncommon for infants to have crackles in their lungs after a cesarean birth. Surfactant is a slippery substance made of lipoproteins and reduces the surface tension within the alveoli to keep them open. Without that surfactant, the alveoli will collapse. Surfactant is first detected at about 24 to 25 weeks, but this is not enough to keep the alveoli open. It's generally in sufficient amounts about 34 to 36 weeks gestation. Betamethasone is a steroid that can be given to mom if she has premature labor before the 34 to 36 weeks gestation mark. This will help increase the surfactant production. The infant's first breath at birth needs to force the remaining fetal lung fluid out of the alveoli and move into the interstitial spaces. This process allows air to enter lungs. Breathing is initiated by chemical, mechanical, and thermal and sensory factors. See Figure 21.1 to see this. After the initial respirations, the alveoli expand and the surfactant allows them to remain partially open to aid in the continuation of respirations. Infant crying helps increase this pressure in the lungs to assist in the process as well. Most fluid is absorbed within the first hours after birth, but it may take up to 24 hours. Thermal regulation is a neurological adaptation that's crucial during the neonatal period. There are certain newborn characteristics that predispose the infant to heat loss. These include thin skin, blood vessels close to the surface, and little subcutaneous fat to prevent heat loss. Newborns have more surface area to body mass than adults, so this increases their risk for thermoregulation issues. There are 4 methods of heat loss in the infant. These are evaporation, conduction, convection, and radiation. An example of heat loss to prevent from evaporation includes drying the infant immediately after birth. To reduce heat loss by conduction, warm all items that will come in contact with the infant's skin. This can include the stethoscope or also putting a barrier on the baby scale before weighing the infant. Providing a warm draft-free environment will reduce heat loss from convection. Being sure the infant crib is away from outside windows and wall will minimize the heat loss from radiation. Shivering is rare in the newborn. Instead, they are experiencing non-shivering thermogenesis, which is the metabolism of brown fat to produce heat. Brown fat, also now known as brown adipose tissue, is a specialized fat that provides heat when metabolized. Figure 21.3 shows the areas of the brown fat in the infant. Preterm infants and those with intrauterine growth restriction may have inadequate brown fat storage, so that puts these infants at risk for thermoregulation issues, including cold stress. Cold stress is when an infant remains cold and issues with thermoregulation. The causes of it can be any of the methods of heat loss we discussed earlier. The more premature the infant is, the increased risk they have for cold stress. There are many hazards of cold stress. These include an increased need for oxygen, a decreased surfactant production, respiratory distress, hypoglycemia, metabolic acidosis, and jaundice. Correction of the cold stress is needed immediately. First, we must determine the cause and then fix the problem. Were they unbundled in mom's room with the fan on and no hat on? If this is the cause, wrap the infant, turn the fan off, and put a hat on is one way. Skin to skin with mom or dad is a great way to increase body temperature. Placing the infant under a radiant warmer is another way to increase the body temp as well. Figure 21.4 has a nice outline of the effects of cold stress. In a non-complicated delivery, labs are not drawn on an infant at time of delivery. Any type of complication or abnormal finding may result in the pediatrician ordering labs. A CBC is the most common lab to be drawn. Of course, they can be looking at WBCs and other values. In general, newborn labs have different values than an adult. Many times, labs do not make that automatic transition to report the infant's normal values. Typically, a newborn has an increase in erythrocytes and an increased hemoglobin compared to an adult. These increases level allows the fetal cells to receive enough oxygen. The newborn erythrocytes have a shorter lifespan than an adult, so they need to have more. The hemolysis or breakdown of all the erythrocytes can lead to jaundice. We'll talk more about this in detail in upcoming weeks. Table 21.1 lists the norms for newborn labs. The hematocrit for the newborn is 44 to 70%. A level above 65% is known as polycythemia. This increases their risk for jaundice and an injury to the brain and other organs due to the blood being thicker and not moving as well, so blood stasis can occur. The norm of leukocytes is 9.1 to 34 and will drop over the next 4 to 5 days to the average level of 12. The levels at birth are higher and are not an indication of infection. Typically, a drop in the WBCs below normal can indicate sepsis. Infants have a low level of vitamin K, which puts them at risk for prolonged bleeding. Vitamin K is synthesized in the intestines, but food and normal flora is needed for this process. Infants will receive an IM injection of vitamin K within an hour of delivery. The capacity of the newborn stomach is about 6 mLs. This is a great teaching piece for new parents. Many think a newborn should be breastfed for 15 to 20 minutes or take 1 ounce of formula, which is 30 mLs. Teaching parents this can help them not to worry so much about the amount the infant is taking. Gastric emptying may be delayed at first. It's typically more rapid in breast milk than formula. Many infants will have a stool while feeding or shortly after. The newborn's intestines are long, which gives them more surface area for absorption. This can put an infant at higher risk for dehydration if diarrhea occurs. The digestive tract is considered sterile at birth. Once they begin taking in breast milk or formula, that bacteria will enter the tract and normal flora is established in the first few days after birth. Pancreatic amylase is needed for digestion and is deficient for the first 4 to 6 months of life. Amylase is needed to help digest complex carbohydrates. That is why they recommend not feeding the infants to cereal until they're at least 4 to 6 months. Lipase is also deficient for that period and is needed for the absorption of fat. Another good teaching point for parents is that this is the reason we wait to feed the infant anything besides breast milk or formula. The baby's first stools is known as meconium. These stools are greenish, blackish in color and are sticky and tarry looking. It's usually passed within the first 12 hours, but we do not get too concerned until it's been 24 hours after birth with no stool. Meconium stools last the first 24 or so hours of life. It then switches to transition stools, which is partially meconium and partially milk stools. Breastfed baby stools tend to be more light brown, yellowish in color, and seedy. Formula-fed stools are more brown in color with a softer consistency. Glucose is used rapidly by the newborn for energy during the stress of labor, for breathing, heat production, movement against gravity, and the activation of all functions that the neonate must take at birth. The stored glucose is used until adequate feedings are taken by the infant. In a term infant, glucose levels should be 40 to 60 at day 1 and 50 to 90 thereafter. Please note that some facilities may have a different protocol of the glucose levels they use before starting treatment measures. We typically are not worried about high blood glucose levels. We are concerned with low levels. Remember what glucose is used for, as I listed a minute ago, and that is why it is so important that the infant does not have hypoglycemia. Also remember, these levels are for full-term infants and not the premature infant. Factors that can put them at risk for hypoglycemia include preterm, late preterm infants, small for gestational age, large for gestational age, post-term infants, infants born to diabetic moms, and infants exposed to stress during or after delivery. A crucial function of the liver is the conjugation of bilirubin. Excess amounts can cause jaundice pretty easily in the newborn and is known as hyperbilirubinemia. The liver many times is immature and prevents the buildup of the bilirubin. It is immature and prevents this buildup of the bilirubin. The main source of bilirubin is from hemolysis of the erythrocytes. Remember, I mentioned earlier that newborns have a high level of RBCs due to their short lifespan. Bilirubin is toxic for the body and must be excreted. When bilirubin is released, it is an unconjugated and also known as the indirect bilirubin. This type is not soluble in water, so before it can be excreted, the liver must make it into water soluble, which is known as conjugation. Once it's water soluble, it is known as conjugated or direct bilirubin and can now be excreted. High levels of unconjugated bilirubin can reach brain tissue and cause bilirubin encephalopathy. If this becomes chronic, it can become permanent neurological damage known as kernicterus. There are risk factors associated with jaundice. Some of these include they make excess bilirubin production, shorter RBC lifespan, fewer albumin binding sites needed to help with the excretion, immature liver of that newborn, blood incompatibility between mom and infant, which we're going to talk more about later, gestational age, delayed or poor feedings, trauma during birth, and cold stress. Hyperbilirubinemia is classified as physiological or non-physiological and is based on the onset and severity. Physiological jaundice is considered normal. It is not present during the first 24 hours of life in that term infant and typically will show up on day 2 or 3 of life. Jaundice becomes visible generally when the levels are 5 to 6. Non-physiological jaundice is known as pathological jaundice and it appears before 24 hours of life. It's caused by abnormalities which lead to excessive destruction of the RBCs, or there can be problems with conjugation of the bilirubin. Some of the problems can be incompatibility of mom and infant's blood types, infection, and certain metabolic disorders. It's often treated with phototherapy, which we will talk about later. To determine what levels are normal and abnormal, there's a chart that you have to look at the age of the infant in hours. This will determine what the correct level should be. For example, you could have an infant at 24 hours of life that has a level of 8 and is considered high, but you could have an infant at 48 hours and have a level of 9.6 and that's normal. To test an infant's bilirubin level, many facilities do a transcutaneous bilirubin meter. This is known as TCB or TSB level. This machine is a screening tool that's placed on the infant's forehead or chest area and will give the bilirubin level. This is something you will see in the clinical setting and will learn how to perform. This is performed typically at 24 hours of life to get a baseline. It can be done earlier if the infant becomes jaundiced before that time. This is a screening tool, so if the level is higher than wanted, a blood sample taken from the infant's foot will be done to determine a more accurate level. Jaundice associated with breastfeeding can occur due to poor intake, which can occur if the infant is having problems latching, mom not putting infant to the breast frequently enough, ineffective suck of the infant, and other issues. No matter the cause of hyperbilirubinemia, treatment measures include fixing the problem, which include more frequent feedings, ensuring effective feeding is happening, monitoring eyes and O's, initiating phototherapy if ordered. Treatment measures will be discussed in upcoming weeks. Infant kidney function is immature compared to adults. The GFR rate is low and will increase during the first weeks of life. Small amounts of glucose and amino acids may be present in the infant's urine and is considered normal. Also, uric acid crystals can be excreted and found in the diaper. They appear as reddish color and many times can be mistaken as blood. This is another great teaching moment you can provide for parents, letting them know that this is normal and the cause will help them be at ease. Most infants will void within the first 12 hours of life, while the rest will void within the first 24 hours. If no void has occurred in the first 24 hours, the provider must be notified so further assessment measures can be done. Infants may only have 1 to 2 voids a day for the first few days, and then increases to a minimum of 6 voids in a full 24 hours. Monitoring for fluid balance is important in the neonate. Box 21.2 provides intake and output guidelines for the newborn. About 75% of the newborn's body weight is water. Vomiting and diarrhea can cause life-threatening dehydration, so close monitoring is needed. Insensible water loss can come from water loss from the skin and respiratory tract. Tachypnea can also increase insensible water loss. The infant's kidneys are not able to dilute urine as effectively as adults, so they cannot handle fluid overloads, which could occur if the infant was receiving IV fluids. Careful assessment of I's and O's is crucial. Acid, base, and electrolytes are controlled by the kidney, which are immature, so many have issues with the regulation process. Newborns tend to lose bicarb on lower levels than adults, so this can put them at risk for metabolic acidosis. The newborn's immune system is immature. Full-term infants did receive antibodies from mom during the last trimester of pregnancy, and infants that are breastfed also received antibodies through passive immunity. The major immunoglobulins are IgG, IgM, IgA. IgA is the only immunoglobulin that crosses the placental barrier, which will provide passive immunity from bacteria and viruses which the mom has immunity against. Preterm infants have less IgG due to its not being the same amount during the last trimester. Newborns can make some IgG, but full levels are not reached until about 6 months of age. IgM helps protect against gram-negative bacteria. It takes about 1 year to reach the adult levels for IgM. IgA does not cross that placenta and must be produced by the infant. IgG is important to protect against GI and respiratory system, so this makes them susceptible for infections in these systems. Production for the infant starts at about 2 weeks of age. Secretory IgG is found in colostrum and breast milk, so infants that are breastfed can receive some protection.